Hi, my name is Claudine Lewis. I'm a respiratory therapy student, and I'm going to go over some ventilator stuff with y'all. Here at Watauga, we use the Draeger Evita XL. The on switch is in the back. It's covered by a clear plastic cover so that the ventilator cannot accidentally be shut off, because that would be terrible. So I've just turned it on, and now we're going to go through all of its little test modes and beep at me. So it does not have a previous patient memory. New patient, let's change the body weight to ideal body weight 55. That's perfect. Accept. We're in SIMB. That'll work. We're going to start ventilating. So, out of ease 1 to 2.9. My frequency is 14. Tidal volume is 380. That's a good tidal volume. O2 is 50%, frequency is 14, PEEP is 5, pressure support is 5. There's the alarm. I'm not getting the tidal volumes that I should be. Oh, there we go. Resistance is 12, compliance is 35. If I wanted to change modes, vent settings, let's go. Where do we want to go? Yeah, we'll do PCV. Pressure control. There we go. Go away. Go away. So, right now I'm holding the test line shut just to see what will happen. Does not like it. So, there's my settings there. So let's say I wanted to give my patient a breathing treatment. I forgot to unhook that again. So I have my T-piece in my circuit. I'm going to take my cap off. I'm going to be as sterile as possible about it and hook up my nebulizer. There's two options. One is to hook the nebulizer up to a flow meter and oxygen at 8 liters a minute, just like you would any other time, to any patient. The other option is to hook it up to the Draeger, which has a port there for that. Hit the nebulizer button, and it will nebulize. Perfect. Turn that back off. So another option for medication delivery is the MDI, which I don't have one. I have a spacer in here made just for that, with a little port on top for the MDI delivery. I would take my inhaler, I would shake it, I would warm it just like normal. It would be an MDI. I would take the canister out of the holder and put there's a little white plastic thing on the end of it and actuate it there. Stop. After I do that, I can do an inspiratory hold. Press and just hold that button for a few seconds. Wait a few more minutes. Spray, do it again. Inspiratory hold. Fantastic. Alrighty. So I'm going to put that back together and it snaps. Once you get it, perfect. And then you don't want your patient to have to worry about overcoming the extra resistance from the extra tubing. So this represents my patient. This is my suctioning, which is in line. So this would always be hooked up to suction, just at constant rate without actually suctioning. So we would jam it down in there. I got lucky that time. Your patient will still try to cough. That is a natural reflex, no matter how sedated you are. And suction back until it's nice and straight. One thing a respiratory therapist here has told me is to hold your own breath as long as you're suctioning, because that's how long they're going without adequate oxygenation. So we have a little port here to be able to squirt saline in and lavage the patient, or you can turn your circuit just a little bit and just suction and clean your tubing a little bit in between suctioning. Never disconnect that. Most studies have shown there's more risk of infection from disconnecting all of that instead of just leaving it all put together. So after doing my suctioning and my breathing treatment and all of that good stuff and assessing my patient, I want to do some mouth care along with my vent check. So I'll look at the ET tube. It'll be in a holder. I'll look at where it's at. This one's 17 at the lip. And I think we started on the right side. So what we're going to do is some of these, there it went. Okay. Some of these actually hook to suction, and so you can hook it to suction and clean. You always want to go from the back of the mouth towards the front of the mouth. I started to say top because they're laying on their back. So you're going to want to clean out. Do the side you're going to move the ET tube to. Move it over to the other side. I would have gloves on. Clean that out. Clean that out. Do the lips a little bit too. Do around the tube. Verify that your tube has not moved in or further out. Make sure you're still at 17 of the lips, which actually I did manage to move mine just a smidge. So I would also check my cuff pressures at this time. I would just take a manometer, which looks very similar to just a blood pressure cuff, but sphygmometer reading, and plug it into the little fill valve on the ET tube. I don't know what else to call that little bulb with the spring in it. And it should be right around 20, anywhere from 20 to 25, maybe even 30, depending on your patient and previous history of stenosis, things of that nature. So that should cover all of that. I think I did. Thank you.